working across the globe. I am witnessing actually probably one of the beginnings, I should say, of major coming together within the greater Houston in trying to probably make impactful work in a collaborative environment. I think always like global surgery is not, or global health in general is not something you can do by yourself. It needs a lot of people. It needs a lot of resources. If you have started a program somewhere, you know that one institution is never enough. And having so much resources, both in terms of people as well as in terms of material resources, in this area is actually a huge benefit. So I really applaud the efforts people are doing to get together and form a coalition and work together. So that said, the students that are getting this movement going are really impressive. It's not even a year, maybe a year and a half, and I'm really impressed by their organization. And I think global health in general and global surgery in particular is really in good hands. So I just want to applaud the organizers and the leaders of the Global Students for Surgery Alliance. And thank you for inviting me. I have no conflicts in my presentations today. And I have a brief 10-minute presentation that is going to highlight a little bit the issue of which is at heart, and I don't want to really preach the choir here in terms of what the problems are. We all know. I just wanted to at least share with you some new ways from the Operation Giving Back perspective we are working at, trying to solve one of the questions that was asked earlier up there, and see if this is something that people can use to form platforms to kind of really join hands. Because if we don't join hands, whatever we do will not be really sustainable. I also want to acknowledge the fact that surgeons in general have been way behind the global health movement. If you look at our colleagues in gynecology, they have been probably about 25 years ahead of us. That means, the funding structures and the understanding of what needs to be done. There's a lot for us to learn. In global health, in terms of definition, for those students who are really getting into this, is really much broader and wider. And I highlighted a few of the words, but it tells you here, that this is really a worldwide thing. It's not something, local. This is something where we are talking about equity. It is social justice. It is something where health is a right, actually. So with that in mind, we have to really get our mindset, not only to think that what we do in surgery is a public health service, but also to get in that mindset that we are actually public health officers. We need to be engaged just like the infectious disease doctors and like the pediatricians and like the gynecologists in that forefront to say, we are actually providing service that is of public benefit. And the numbers are there, so the data is there. So it doesn't make any more sense to really spend a lot of time in trying to find more data, because we know the amount of death and destruction that's happening out there because of lack of surgery. So we have not been there, and we have a very good presence. WHA has now even included that we need to be included in the universal health coverage, and we need to look forward, and I hope in advancing global health, our presence is going to be absolutely critical, and we will be to task. As you all know, surgery, you cannot imagine a hospital without surgeons or without surgery. If there is one in the US, it's usually a hospital that's not going to do well. And so imagine for a minute places where there is no surgeons, but there is a clinic or a hospital. So it is really a very interesting thought when you think about it, because when all these structures are being built and excluding surgery because surgery is expensive or surgery needs a lot of material resources and so on and so forth, actually has been disproved. So that misconception, we need to really get to the bottom of that and be able to explain to policymakers, to funders, that our general surgery procedures can be as equally beneficial as vaccinations for that matter, or others. So despite the world coming together probably more than 40 years ago for the first time, just trying to articulate what health means for the world population and what it also means for governments to be accountable and for it also to be actually a human rights issue. So that happened about 40-something years ago. And the goal at that time was to get health for all by 2000. And as you all know, we're not absolutely there. And from 2000 to 2015, just because we're not there, the Millennium Development Goals were declared. That has made a lot of significant actual improvements. 2015 is gone. We are now in the Sustainable Development Goals. When all this was happening, surgeons have not been at the table. Probably from the Sustainable Development Goals perspective, maybe at the tail end, we were shouting and trying to be part of this. But what you see is, in the Sustainable Development Goals, health part, which is important, is actually important in covering or touching all the other 17 goals. So we have a major role to play from surgery perspective, and I would like to encourage everybody to really know the detailed content of what SDGs are, so that you will know and discuss intelligently as to what your impact and participation can be. These numbers are not new for anybody else, right? It's really incredible. There's a lot of badness here. I was really struck to see the 35% women worldwide have either intimate partner violence or non-partner violence. These are really issues that are incredibly important for us to know and be part of. And I know earlier, Sandy mentioned about poverty. We need to be aware of this. This is a curse. This is actually one of the biggest problems. More than surgery, this is the biggest problem where we have to learn about it and be able to stand up to it and try to participate and advocate for the eradication of poverty. This is the #1 issue actually when you look at the Sustainable Development Goals as well. The bar, the extreme poverty, which is set at $1.25. The statistics says that there were probably close to 2 billion people at the beginning of the century, and that number went down to 800 million people living with less than $1.25. I'm not sure how many would be under $2. Think about that. So the poverty issue has to really be our issue. And I think as surgeons, we have to think about this. And as Nelson Mandela said, this is not just like an apartheid, it's a man-made issue. Education. We talk about education all the time as surgeons, training somebody else. But I think if we are looking at up there where someone has gone through medical school and then is coming to surgery, that's not enough. We need to know there is more than 20% of the children in the world are not in school at this time. And if you actually look those between ages of 11 and 17, about 33% of them are not in school. So there is a big education gap that's critical. A country that's educated is always healthier and also wealthier. So I mentioned this not to, to preach, but I think we have to get to those kind of basic thinking when we promote global health. And it's really important to arm ourselves with the knowledge of these things are critical and important. This statement, which some of you may have seen, is back from 1980. This is the Director General of the WHO. It's interesting that since 1980 and up to 2 years ago, I mean, the statistics and the definition did not change. So there is a lot of catch up we have to do, and we have to really be aggressive about it. And to do this well, we cannot do it in individual silos. We have to come together. We have to find common goals and agendas and figure this out together, because this is not something we can solve by, the University of Wisconsin or Chicago or Texas Tech. So this is really critical and important. I have this slide up there just to make sure people know that there is literature, ample literature to justify that surgery can actually save lives in a very economic manner with the benefit ratio 10-to-1. And so that's an amazing investment. And so we need to be armed with all this information when we are really tackling the issue of global health. The next few slides are a little bit about what we are doing in Africa. And I bring this up because from Operation Giving Back perspective, we have been spread thin. Everybody's everywhere, and you cannot accomplish much. And because the question was raised about being in a place for a month is not enough. You have 11 months, nobody there. And even if you are there, that 1 month, having just only clinical work is not enough. We need to think about healthcare strengthening, the structural part of it as well. And to do that, I think it is very critical to think this by bringing all the elements that make a system. And with that in mind, we have been working for about 1.5 years to identify what we call ACS-COSECSA Training Hub. This is chosen in the COSECSA region. For those of you who don't know COSECSA, it's the East African College of Surgeons. We wanted to really work in that area because the need is the greatest. The impact is going to be also the largest. And in this area, we have been working with the regional college to identify a site where we want to pilot. What does it take to create an environment where multiple programs, as was suggested earlier, would participate and make a sustainable impact in one particular place? How can the College of Surgeons here in the US be a good partner and shepherd that activity and create that platform in such a way that our learners, be it students or residents, can also have a place where they can go and learn in a way that is nicely controlled in a way that what they do is not going to be without any purpose. So with that in mind, we are just at the final stages of getting this nicely organized. We have actually identified a location in the southern part of Ethiopia. And this location is going to be the place where we're going to be uniting few surgical programs as a pilot. We have about 14 surgical programs that have raised their hands right now, and we are going to start with them. And hopefully, in a year from now, I'll have a better report as to how this is going. And the program in that part of the country is actually excited about this. There is a lot of good, future young people that I think are promising. This is a picture of COSECSA fellows that we have provided scholarship from the college today. We are really investing on these women because I really think that is the part that is absolutely critical. When women are educated, 70% of the time, poverty gets eradicated too. So we need to get to that principle and try to make sure the those who want to be surgeons in COSECSA region, particularly women, are encouraged. Right now, they are only 5% of the surgical work. So final thought, there is a lot for us to do in the global surgery world, in the global health world, if you will. 80% of the population lives in places where we can help and support and learn. And actually, more than learning, we can actually innovate. We can be, this is an amazing laboratory we can get into. So it's very, very critical. So I have two pictures here. The one on that side was taken back in 1970. And the one on this side was taken in 2014. So a lot of years of difference. When you look at the kids, you can see a lot of things if you look at those pictures from close by. Some have no shoes, some have torn t-shirts, some have no pants, and here you see these are all girls. The thing is, I think these young girls are probably the future actually in that part of the world, and I think I see them as probably the future saviors. In this picture, if you look at this picture, the three people, one has become a finance person, one has become a veterinary medicine doctor, and the other one on the left is a surgeon. So I'm emotional about this because if you go to Africa in general, you see millions of people. And I really think this is our common calling and responsibility. So I really want to ask everyone to do whatever they can. And I know there's a lot of people putting a lot of effort and energy. But this is a calling. We really need to work together and change people's lives. And that's why we are physicians. So thank you for the opportunity.
I'd like to welcome our next speaker, Dr. Larry Hollier. Dr. Hollier serves as the Surgeon-in-Chief of Texas Children's Hospital, as well as the Chief of Plastic Surgery at the Baylor College of Medicine. He was named Physician of the Year for the United States in 2016 by Press Ganey. In addition to organizing and participating in numerous educational and capacity-building surgical projects in Asia, South America, Africa, and the Middle East, he serves as the Director of the Baylor Global Surgery Fellowship. He also serves as the chairman of the medical board of Smile Train, helping supervise safety and quality in over 100,000 pediatric surgeries in 85 countries around the world. Please welcome Dr. Hollier.
Thank you so much. I very much appreciate the opportunity to speak here today. I'm sorry I tend to disappear behind these podiums. I get out when I can, but it's not set up that way. It was so wonderful to hear Dr. Tefera speak. Hard act to follow. I probably should have gone before you in retrospect. I want to speak today to what I feel is a very sustainable and scalable model for certain surgical conditions that we face. I'm not going to re-emphasize the need. I think we all in this room appreciate the need. I do want to discuss, though, what the classic medical mission model. There is no question that this is of value. The people, children, helped by these trips are the better for it. I think most of us, however, realize there are issues with this. Clearly, they tend to be inefficient and relatively costly, and clearly this is difficult to scale for significant conditions around the world. We have problems learning what the outcomes of these trips are, and certainly continuity is an issue. And finally, there has to be some disempowerment typically, or disruption of local healthcare system. Some trips do a much better job of involving local providers than others, but it is always an issue. I want to say one thing. We discussed the duration of trips, and it's a fascinating thing. You don't hear very much about this. There was a great study done, and it was in Peru. It was a surgeon that I know there in Peru, and he was involved in cleft care, and he always went to this small remote town, and he went for the classic week at a time. But then they developed a little, what they called a referral center, but it was basically a building where they could do these procedures. And he took the people that he always went with for a week, and they stayed for 6 months. And they looked at the patients and the outcomes that they had when they were going for a week at a time, and those after they were going for 6 months at a time. And you know what? It was fascinating. When they stayed longer, the patients did better. And we're talking about cleft here. Decreased palate dehiscence, decreased bleeding, decreased fistula, and better follow-up at a year. The patients tended to develop a relationship and came back. So I don't want to dwell on this, but there is something about staying longer. Now, obviously, the best thing is to not have surgeons traveling to another country and doing it. Clearly, the best thing is to have local providers taking care of the people that they live and they work with. It was also more cost-effective, as you might imagine. So I'm going to speak to an organization that I chair called Smile Train. Now, Smile Train is always confused with all the other smile terms. Operation Smile, smile this, smile that. We are the opposite of that. The one thing we do not do is send a surgeon from this country or any other country to another country to operate. That is exactly the opposite. What we do is focus on local providers, and all we do is cleft. There are many reasons behind this, but we feel cleft is a very treatable problem, and it's a massive problem. The most common facial deformity, if you will, in children is cleft. It's clefting. And it's not just an appearance problem. It's a problem with the way they eat, with the way they speak, with the way they hear. It's a huge, huge issue. And these children become socially isolated and basically have a minimal future moving forward. And very often the families become isolated. So we were founded in about 1988, 99. As I've said, we identify local providers, surgeon, anesthetist, and nurses. We also establish or look for good facilities. If we can't find a local provider, we focus on training them regionally. We have regional centers of excellence, high volume centers where we feel we can train these people very effectively. If the facility is not safe, and I'm not talking about a standard perhaps that you are used to here in this country, but there are minimal standards that we require. There are minimal things that patients need for a safe anesthetic. And postoperative care, obviously another huge issue. Once we've established this, we set up an account in the country. Now, we fund activity on these surgeries, but we don't fund it until we have seen that the patient has had a safe, high-quality procedure. And I'm going to go into this, but typically the funding is about $250 per procedure. It might not seem like a lot, but in some of these low and middle income countries, particularly when you do any volume of these surgeries, this goes a long way to funding an entire facility, sometimes an entire hospital. I'm going to give you an idea of the results that we have had with this. We've had, I say over 1 million, we've had closer to 1.6 million surgeries since the time we've been around. We have about 2,000 partner hospitals in over 85 countries and over 1,000 partner surgeons. You can see the distribution of our procedures there. This has clearly been not just a sustainable, but a scalable model. You can see since our inception around 2000, when we got going at any clip, by 2009, we were well over 100,000 children a year, and we have maintained that for quite some period of time. That is a very, very stable number. I'm not going to start going into all the demographics behind this, but it's a fascinating thing. When you look at many of these countries, we have caught up with cleft births. So we are doing basically all of the primary cleft repairs in these countries. In India alone, we provide the majority of cleft care in that country, in that massive country. Now, I want to be very clear about this. Anybody can pay for surgery. That's easy. What is difficult is monitoring and ensuring safe, quality surgeries. I don't think that's entirely possible for every surgical condition, but I would put forth to you that the relatively simple surgical conditions, that is something that you can do. So, as I said before, we have very strict quality and safety protocols for which the providers have to sign a contract with us. We have local personnel, field personnel, who make regular site visits to these facilities to make sure that they're maintaining their facilities and their quality. We have annual surveys, and most significantly, we have a proprietary online database. We call it Smile Train Express. But it allows us to gather records and score results. So with CLEFT, it's a very visual thing, and we score all of these results. When a provider, when a surgeon falls below a certain quality score, we pull that out and we subject them to more rigorous analysis. If they continue to score poorly, we subject them to a regional training in one of our centers near that country. To follow that, if they continue to score poorly, we terminate the contract. It really is that simple. You know, I could give you many examples of how successful this has been, but when we started, one of the countries we really began in was China, and at the time there was a huge need. And after a period of time, we were so successful in China that they began realizing that it would be better for them if they helped us fund the surgeries. So they partnered with us, and to this day, cleft surgeries in China are funded half by Smile Train and half by the government of China. The goal for this ultimately is to really give back to the local economies, I think, and make sure these children are successful and have productive futures. I will tell you, in 2016, an outside medical group asked to evaluate our data, our results. And they looked at a 10-year period of our surgeries in these countries around the world. And they estimated, based upon disability-adjusted life years and other parameters, that for a $250 investment in that child, there was about a 168-fold return to the local economy. And they estimated in this article published in the World Journal of Surgery in 2016 that Smile Train had had about a $20 billion impact around the world because of these simple cleft surgeries. I put this forth to you not as a solution to everything, but as a potential solution to cure fairly simple, straightforward, elective surgical problems around the world. Again, anybody can pay, but it's very, very important to maintain quality and safety in the surgeries that we sponsor around the world. Thank you very much for your attention.
Our next speaker is Dr. Michael Belfort. Dr. Belfort is professor and chairman of the Department of Obstetrics and Gynecology at Baylor College of Medicine and obstetrician gynecologist in chief at Texas Children's Hospital. After his graduate medical education and his internship, he spent 2 years in the military and subsequently earned a diploma in anesthesia before beginning his first OBGYN residency at the University of Cape Town, which he completed in 1989. He has a postgraduate MD from the University of Cape Town for his thesis on neonatal brain blood flow. He completed his second OBGYN residency at BCM from 1989 to 1993, and then did a MFM fellowship from 1993 to 1995 at BCM. He then went on to earn a PhD in Sweden. Please welcome Dr. Belfort.
Afternoon, everybody. It's great to be here, and it's wonderful to see this remarkable group of young people and especially these Baylor medical students that I'm in awe of. What a great future we have in medicine with people like this to look forward to their careers. I want to talk a little bit about our program in women's health in Malawi and talk a little bit about our journey, and I tend to over-talk, so I'm sure somebody will help me remember that I should shut up at some point. I think that a lot of people know about maternal mortality, but it's quite sobering to think that in 2010, every 2 minutes, more than 700 women became pregnant, 380 faced unplanned or unwanted pregnancy. 220 every 2 minutes experienced a pregnancy-related complication. 80 women had an unsafe abortion, and 1 woman died every 2 minutes. And 99% of these occur in the developing world. And why are these women dying? They're dying from the 3 delay model. Delay in deciding to seek care, delay in reaching an adequate facility, and then delay in receiving adequate care at that facility. I'm not here to lecture on these things, but I think it is important just to reiterate these principles. Why do these women die? Globally, hemorrhage is the largest proportion. Hypertensive disorders. These are things that can be treated. These are things that we can actually take care of. They're avoidable to a large extent. And you can see the rest of the causes here. Again, you can see these kind of maps, and the inequity of maternal mortality is very clearly demonstrated right here. This is where mothers are dying. So when I arrived back in Houston, I did my residency and fellowship here, and then I left to Utah for 14 years. When I came back as chairman, one of my dreams was to build a global health program. And the foundation for that was to be an educational opportunity that not only served our medical students, residents, fellows, faculty, and learners, but was really based in serving the African local communities and physicians. And I think that anybody and most people in here involved in global health, you understand the issues in countries that don't have specialty and subspecialty training, is that they send their people, often at government expense, to medical schools outside of their country. Those people get excellent training and never return. And there's this brain drain. Or if they do return, they're unable to practice what they've learned because the facilities are neither there, or they go straight into private practice. And so it just doesn't work. So educational opportunity was very, very important. The other leg, if you will, was to provide clinical service. So our program is designed and was designed at its inception to do 2 things. Provide service firstly to the local population and train the local population. The research efforts are definitely built on top of those first 2 things and are not anything that we rely on. And that's a difference to a lot of programs that we have seen in the developing world. We wanted to impact, in particular, maternal morbidity and mortality. We chose the country of Malawi after a reasonably protracted visit, where we visited a number of programs in Uganda, Tanzania, and Malawi. As part of the BPI, the Baylor International Pediatric AIDS Initiative program, there were, at that time, I think 14 centers of excellence throughout Africa. And we visited, or chose 3 of them, and we settled on Malawi for a number of reasons, which I'll get into in a second. But the country of Malawi, for people who haven't been there or don't know it, it's a long, thin country along Lake Malawi, population of about 17 million. And you can see these statistics here. But what I wanted to point out is that it's got the 7th highest birth rate and one of the highest death rates. The median age of the population, as was shown earlier, is very young. A mother's mean age at birth is around 18 years, which is really, let's look at other countries in sub-Saharan Africa, almost geriatric. Life expectancy is good, and the literacy rate is excellent. And these are important facts for us. But when you look at the health demographics, 0.02 physicians per 1,000 people, 1.13 hospital beds per 1,000 people. Very small proportion of GDP is spent on health. The total fertility rate is very high, and the infant mortality is very high. So we set out with our program with a number of guiding principles. We wanted a team-based model, and a lot of these I have to give the shout out to a gentleman by the name of Mike Mizwa. Some of you will know Mike, an astounding man who's the CEO of the BPI organization. And he has set up these centers of excellence and worked with Dr. Mark Klein, who started BPI. Very much in the team-based model. So we wanted to fit in with what was already there and leverage our program off the infrastructure that was present. We wanted, of course, the highest ethical standards, accountability, and responsibility. It was key to have, as Dr. Hollier mentioned, something that's scalable, replicable, and self-sustaining. And again, as I've said earlier, we wanted to base our efforts on education and local capacity building. So we went in May 2012 and settled in Malawi, as I said. The building there you can see is the Baylor College of Medicine Abbott Fund Children's Clinical Center of Excellence in Malawi. This is set up as an NGO, and it's Baylor Malawi as an NGO. It's run by local Malawian principals, but it's run through Baylor as a Baylor corporation, which makes a lot of sense. It has the full support of the Malawian government and Ministry of Health, and there are no decisions made there without a top-down structure. I think that we have seen a number of organizations come and then very rapidly go because of a bottom-up approach, where somebody has a relationship with a doctor in a small hospital and they show up with a team of people, or they come to an institution and the entire effort is then subsequently undermined by other people who didn't know about it, didn't want it to necessarily happen, had ideas that they didn't think it was the right place, and that the whole thing is shut down. Our principle is we don't do anything without the local people, the Ministry of Health saying, this is an issue, this is what we want. We don't care what you want, we need this X, Y, and Z. And so that there's instantly that need, and we're there to serve their need. I think that is something we have to bear in mind at all times. So why Malawi? As I said, it had a clearly identified need. We had a shared vision. It's a stable, safe country, and it certainly had the clinical volume. We also had the partners in BPI, visionary leadership. We had longevity in the region. They'd been there for about 10 years. And here's the Center of Excellence. You can see this is a well-built, well-constructed, safe area that has been around for a number of years, and they've got, the BPI organization now has 300,000 children living with HIV in treatment. This has just been a remarkable, remarkable story. And it's been funded by, as you can see, the Abbott Fund. It had PEPFAR funding, USAID. It's been a well-funded, well-run organization. All of the infrastructure that we use came through BPI. Visas, medical licensure, checking of the paperwork, doing all of the paperwork that's involved in running these things correctly. The last thing you want to do in any of these programs is end up in conflict with the local health authorities, or being accused of malpractice and then finding out you don't have malpractice coverage. So all of this kind of paperwork stuff is critically important if you want to be sustainable. We have a house. This was when we got the house. I promise you there's now furniture in the house and cutlery. It is a 6-bedroom house, and our program is set up such that we have in-country, US-trained and board-certified faculty that live there. As Dr. Hollier was talking about, it is really important for us to maintain a presence and have an ongoing presence. We have transportation, we have security, we have all of the needs so that we can take care of people that live there and people that visit there. One of the very first things that we did was look at establishing in this country that had no specialty training for OBGYN, a residency program for local Malawian physicians. And we went through a process of working with the Malawi College of Medicine and started a residency program in OBGYN. It began in October 2013, and the first 4 residents have just graduated. We set up the curriculum, we helped with mentoring, teaching, we provided faculty for these people, and I'm super, super proud of this. And at the end of this 4-year cycle, we have handed that residency program back to the Malawians. It is theirs, we're there to help, but we're not running it anymore. And that is the entire purpose. It's help where we can and leave something sustainable. So this was a huge collaboration. Big shout out to Jeff Wilkinson from UNC, who did a huge amount of work, Susan Rain from Baylor College of Medicine, and money from Texas Children's, the University of North Carolina, the Norwegian government, and the CDC. Here are our first 4 graduates. The other thing that we established was a Global Women's Health Fellowship. This is not an ABOG or ACGME recognized fellowship, but we went through the process with the Texas Medical Board. So there is an accreditation, and there is a formal fellowship that we run along the lines of ACGME. So anything anybody in an ACGME fellowship does, we do. We run at the same standards. We currently have our fellows participate in the CSTP training program. They also do the National School of Tropical Medicine course. 2 fellows are on site in Malawi for virtually their entire 2, oh my goodness, 3 minutes left, okay. For virtually the majority of their training period. One of our first graduates, Rachel Pope, focused on obstetric fistula. We have a fistula unit there that I probably won't have time to talk about. But she, on graduation, ended up being offered the leadership position when the physician in charge left. And so she now runs one of the busiest fistula units in the world, and is doing quite incredibly well under the help and supervision of Jeff Wilkinson. And one of our other fellows, Heather Lytle, focused on antenatal care and HIV-positive teens. So there were tremendous opportunities for US learners. The other thing that we've done is, because we've got US board-certified physicians on the ground, our residents and the residents from other programs in this country can visit there and get RRC-compliant training. It's not medical tourism. It is, in fact, part of their residency training. And what I wanted to talk a little bit about, and hopefully in the discussion period we can, is how can we leverage these resources and the infrastructure that we have there to the benefit of other programs in the United States. And I will say that from an OB-GYN perspective, we're open. We've had med students and residents and fellows, in fact, come from Columbia, from Stanford, and from, 1 minute left, okay. Wow, she's strict. We've had a lot of people that have come and used our program, and at some point those programs need to give back. So we'll talk about what this giving back means. Opportunities for US faculty, you can see we've had all of these people out there. Jeff Wilkinson, let me give a shout out to Larry Hollier. When you talk about obstetric fistula surgery, there are a number of levels. The first level is try to make the woman dry. And that's what a lot of programs do. The next level is try to make that woman sexually functional. Because often in the making of the woman dry, they need to do surgery that ends up with somebody who has no sexual function. And Dr. Hollier took Jeff and Rachel to LSU, provided at his expense 5 cadavers, and the plastic surgeons taught the OBGYNs to turn gracilis flaps and other sophisticated flaps that have now allowed the creation in their patients of a functional vagina. So you have a patient who goes home not only dry, but she can reintegrate into her family, which is absolutely key. I'm not going to talk about that. We run the obstetric fistula program now on Mercy ships. Jeff Wilkinson and Rachel Pope run that entire program and are training people. Mercy ships, for those who don't know, sail around the world really and dock in these ports and stay there for a period of 3, I think, to 6 months, during which time they do a lot of service and train a lot of people. And here's Rachel presenting a certificate and some surgical instruments to a local physician who's going to go on and do the good work. Global surgery, we've spoken about. The last thing, if you'll give me a few minutes, Area 25. And this is important because this is a facility and infrastructure that I'm offering and Dr. Hollier is offering to people in the Texas Medical Center or around the country, of those people here who want to participate. We believe this is a sustainable model. The public-private partnership with the Ministry of Health in Malawi, we are building 4 operating rooms that are added to a midwife birthing center to make sure that women who are in labor, instead of getting to a point where they now need a cesarean section and have to wait for an ambulance, which takes 6 hours to get them to a tertiary care center where they can have surgery, they've got it right there. This is going to prevent the massive complications of obstructed labor. So we've got funding for this. It's being built. In fact, the roof is already on. This picture is a little bit old. And we're going out there in May to dedicate this unit. We already have a number of people who are coming with us from the Texas Medical Center. Attached to this is a maternity waiting home so that women don't come in labor. They come a few weeks before the expected date of birth, and they stay there, and they live in the maternity waiting home, which was funded by Gates, by the way. And while they're there, they're taught permaculture. They're taught to grow food, to cook healthy food, to look after their baby, and it's quite a tremendous program. I love it. We've even got an ambulance that Jeff managed to source. So I'm going to leave it at this. I think that Rachel Davis is here. She will tell you about our global surgery program that is being offered later this year. And I'm going to stop right now, I promise. It's always going to be about the women and the children for me. Thank you.
Okay, our final speaker for this capacity building session is Dr. Geelhoed. Dr. Geelhoed works as a professor of surgery at George Washington University Medical Center. He's the founder of Mission to Heal, a nonprofit organization through which he and his team provide surgical services in the most remote areas of the world, using the mobile surgical unit as their essential tool. He also provides medical training to the indigenous population to ensure his work has a sustainable and culturally embedded future. Please welcome Dr. Geelhoed. Thank you.
What am I doing here? Very much more important, what are you doing here? Because don't I come from a tertiary medical center? I came from sort of fly-by-night organizations like Michigan, Harvard, Hopkins, George Washington, and National Institutes of Health. And I was the chief of transplantation. And we're talking about the developing world. For heaven's sakes, isn't this surgery light? Isn't this for people who can't cut it in the real world and have to go out where there's no competition? Well, we have robots that operate in my institution. We have 47 colleagues for every one of us on the full-time faculty that can give advice. We have lasers, and we have endoscopes, and we have radioimmunoassays that make diagnoses. And where do we fit? And how can we do something abroad? Well, we can feel better about it if we go out for a week, and say something good about how many patients we took care of. I'd like to say that last week, 58 operations were done during my last 3 days, and I did none of them. I did the last 2 without putting on gloves. Because my job is to work my way out of a job, and to do that as smoothly and rapidly as possible. And we've had actual performances of graduation ceremonies when the handover has been complete. And 3 years is the limit in which we will return, raising up to a new level each of those years, by which time they should be floating on their own bottom. But we will return if they adopt a daughter clinic that started where we did, and they then take the responsibility of bringing them up to the same speed. This is my commencement address finale here. What do you need to know to take care of another, especially in an environment where you don't even know the language? You don't know what the currency is, don't have any idea about the cuisine. You don't even know how to speak to these people. There are only two people, classes, I think, politicians and physicians, who say about others, I know what's best for you. Come on, you don't even know me. How is it that we can go there with any kind of credibility, let alone authority, and learn from them, which is the fundamental rule about every one of us that goes. If you're not prepared to learn a whole lot more than you teach, it is of no consequence that you do leave home. After all, you have air conditioning and flush toilets here. Is it possible to take a piece of the first world into the third world as a training unit and get them up to speed? And how is it possible to do that without learning something rather rapidly about how it is that we can take care of these folks through what they're already doing, empowering and enhancing their own care? This is the year, 2018, as a tribute to the Millennium Development Goals. For the first time in history, plagues and pestilences aren't the hallmark of all of human problems. After all, yes, if I were going to really impact the world, how would I go about doing that? I have several ways of perhaps trying that. One of those is my prized protege. I'm proud to say that one of my most able students in residence is now sitting at the chair of your department here, and Barbara Bass is also the American College of Surgeons president. And if she comes to Houston, as she did, she could, with a lifetime of effort, perhaps improve by at least a percentage point the quality of care here. As a freshman medical student, you make 100% difference on your first day. You can't fall off the floor. So any kind of organization and any kind of thing with a purpose that is going to be present and indigenized is going to last beyond you. And I'm at an age and stage right now where I have to think about that piece of it. After half a century of wandering the world, what is that going to happen in the next half century, and how can it happen? So public health is now a focal point around operations, because after all, congenital, traumatic, oncologic, and a number of the ordinary structural defects. People said, no, you can't do operations in developing world. It's too expensive. Well, maybe we start with liver transplantation as a model. I don't. I think of maternal disasters. Ruptured ectopics, DNC, C-sections are the 3 of the 5 operations that start with our first mission. And I think of hernia repair as one of those things that has to be taught, and taught quickly. So this is the year things switch. If the model is a cardiac operation, which of course is what fills a good number of the beds here in Houston, remember that disease isn't really there, except in urbanizing environments where it's becoming a rapid plague, along with metabolic syndrome, another mark of development. So what we're doing here is to say, what can we do to indigenize care in the area where it's needed most? And I'm going to point out one continent because I'm an Africanist, despite the fact that I might meet you the other continents each year as well. That's the continent that has the fewest resources. That's the one we might be able to do the most. And if the people there think of themselves as unworthy of being modern, they rely a great deal on their indigenous care, meaning non-medical, some of it traditional. When they see the results of what happens from an operation, not from someone off an aircraft, that is not healthcare, someone locally full speed ahead and perhaps trained. And how did that birthright fall to you? I'm an immigrant. I mean, maybe 5 to 6 generations later. So I wasn't entitled. If I wasn't entitled, they certainly should be entitled. Is there a way we can do this for people who are too poor, who may not even know about the disease? As you just heard, they may not know about renal failure. I was a chief transplantation for 30 years in Washington, D.C., and I knew that a number of those people thought, well, it doesn't really matter because whenever I'm ill, someone is going to be responsible for my health. They'll take care of me. It's not my job. Perhaps these people will graduate from that primitive to the rather primitive modern part of hoping someone will take care of them as opposed to being responsible for their own livelihood. If those people can't be found or can't find their way to care, certainly can't afford it, especially if it's in an urban environment and they're rather suspicious rural people, especially if the religion changes when they go 20 kilometers, especially if the language is unfamiliar to them, perhaps we can bring the operating room to the person who cannot find their way from their center, their living area, to an operating center. So we propose a couple of thoughts here. One of those is from an environment where we can use, for example, this worthiness as a common denominator for all of us who draw breath. Perhaps we can go there and then there bring to that area a spot of excellence that we can backfill. Not necessarily going to the center of the town and not necessarily going to the place where there's cash economy, but going to the rural area. And if that's possible, we can operate there as a training unit and have that indigenized care continue there along with some of the equipment, some of the supplies. We must leave the skill behind. And if that is a model, I propose that that is possible because we've done this without anybody's big grant. Big organization that funds me is called American Express card. And as a consequence, it is possible from this small scalable model to move forward right now with these mobile units on 5 continents. So if that's possible, perhaps we can do this. We can take the furthest peoples first, the title of the next book that's sitting there in manuscript form on the table outside. And you will see that with the furthest peoples first, it is possible that we can indigenize that care and then have it brought back. This means that we are working our way out of a job. I should not be present there. Like the Cheshire Cat, I should disappear with only the smile left behind. And if that is the case, how can we do that without getting what I call 3 very short and simple steps? For World Bank purposes, I will say it's a very short jump from advocacy to agency to ownership of another people and the problems that they might have. Stay out of my area. I've got control of it. Next year, I want you to double my funding. Wait a minute, you've got control of the area. You're making great progress. We should have your funding. You should have less in need. Well, no, I've got this big organization. See, it does fundraising, and I've got an organization at home. No. Our process is not to build an administrative structure. It is to indigenize the care so that they think, hey, I've always known this. And of course, I got a little help by, what's his name? I can't remember. He was one of those white guys, but he just came and went. Really, my mentor is my senior partner here, which is what it should be. So these are all training missions. They should all be education. And what is it that we do? We do 3 things, and we do them well, and we do them in 3 different sites. One of those is by temporary remote case, and everyone says, hey, you can operate under a tree, but we need air conditioning, we need endoscopes, we need everything. No. We do what we can with what we have there. Second is the mobile surgical unit, and I'll propose that. And then the last is some sort of local clinic and enhance it with whatever the skills, as you saw, a birthing center can have an operating facility. So Mission to Heal had that idea. And the 3 things we do, one of them supremely well, and that is transformational learning. You, along with your indigenous partner who will be your same age and stage, will be learning together. You probably faster than they, because we have a whole lot more to learn about them than we do to teach them. Second is that we do pretty good care of the bottom billion. The third we have to work on, and that's indigenizing the skill. And the way we do that is two things that are major, and they are the ones that are teaching us. Ingenuity and improvisation, to do workarounds from the limited things that they have. You can't make up with stuff what you lack in the motivation and the skill. My job, as I see it, I require but do not furnish the motivation for this experience. That's BYO. Come and let me learn from you, because you might pick up mine, but you might pick it up 52 years too late. You are that future, and I'm going to follow you. So this is what I call the gifts from the poor that we bring back. How to do more with far larger numbers, with far fewer resources. And we are the students of that postgraduate experience, having to learn from them. They've been to that school. They know how to cope. That's what they do for a living. One of my heroes and a very good friend, we together have worked together 30 years, was Dr. Edgar Rodas, an honorary fellow of the college by a nomination that I'm proud to say came from One Direction here, and his son. For a long time now, 7,000 patients without an operative death. Been working in Ecuador in the Andes, and it works well. My second mobile surgical unit is dedicated to Dr. Rodas. Here's the first one. It goes through Asia, 2 operating rooms in a trailer, air-conditioned, laser-equipped, endoscopic, everything. It works. We've just taken it last month, because I was in Africa last week. The month before, we went to the typhoon-devastated islands of central Philippines, Mimaropa, Mindoro, Marinduque, Romulan, and Palawan. And then we are by ferry, the Ro-Ro, roll on, roll off, carrying it to those inaccessible places, and then carrying it through the mountains. My pride and joy, for which reason I'm back, is out of Breda, Netherlands, come 4 purpose-built container, 9 times the specifications of a military unit in terms of their strengths. Air-conditioned, positive pressure, keeping out the dust and the mosquitoes, and entirely self-sufficient in their energy, making their own IV fluids, powered by the man-cat 6-wheel drive diesel that will go through the Ituri forest, skip the bridge, go right through the river. We've never been able to get them stuck. Going in paired units. For those of you who have first world preferences, for the first time, you don't have to be the adventure traveler that I started out, flush toilets and hot showers in the second unit. All of these things now are there as a training unit for those people who are the go-to folk that we have to help care for their folk. The American recruitment vessel follows a Unimog. It will be replacing the Centurandis in Ecuador, extending into Paraguay. Are you ready? If you can, if you must, welcome aboard. It was George Bernard Shaw. You probably don't have a whole course in him in the medical school, but the fact is, I think he said, do not attempt to live forever, you will not succeed. Well, now, you don't need to know George Bernard Shaw or his wisdom about morbidity or mortality to understand that. But with that fundamental fact that I think most of us are quite familiar in the health profession, you have but 2 choices. You can spend your life, and I don't know how much your life will take, I suspect not very much, or you can give it. I don't know how much it will take, but I do know it can give and keep on giving forever. Thank you for your attention. I look forward to your questions.
I'd like to invite Dr. Tefera and Dr. Belfort to join us in the front. Dr. Hollier had to step out to catch a flight. I will now open it up to the audience for questions.
I just wanted to thank y'all for taking time to prepare your presentations and speak with us today. My question builds off of even the first part of the conversation. Dr. Guy had a slide on like the heart of the work, and I'm curious, y'all have your expertise in different areas of medicine, and a lot of the groundwork that needs to be done before going to serve in other countries involves working with other providers, etc. So I'm curious what preparation and time is spent towards learning the cultures of the people there. And this has been touched on in various ways. And in researching, some people have actually spent time like getting degrees in other cultures. So that's kind of like a tangible question about what preparation is done to learn about the populations before leaving that's separate from time spent preparing for surgeries that you do or communicating with the other surgeons that you'll be working with. Thank you.
Well, I think this is a great question. It comes up at different stages of your surgical development, if you will. Some are already graduating residents at the beginning of the residencies, and there are students like here. So, as I was mentioning earlier, I think unless we think about this in a much broader sense, in terms of public health outreach programs, if we think only from surgery point of view only, I think that would be very narrow. So this is why at students level, I just want to encourage you to think much broadly. There are, as I was mentioning, the education, the poverty eradication. There are some basic health related things that can be thought. So there is a whole bunch of things you can do. It really is something you should, of course, probably not take it on by yourself. You need to have, as usual, the mentors or the organizations that can include you and involve you. Starting early, I think, is a lot better than trying to get to this later. Starting early will give you a much deeper perspective about where your passion is going to be, what exactly you want to do. And we also see that when people go back at this again and again, they actually get better and they do more. It keeps on giving to you as well. And so it's something you can start at any time, really, as far as you have some kind of a support mechanism that can show you and mentor you as to the road you're going to travel. So it's like any other education. So that's how maybe a very simplistic answer, but that's how I see it.
Well, your life experience is the most important, and the more varied it is, the better that I would be able to share and learn from you. I have a wonderful time with the students and residents that come with me because I learn from them. They think of me while I'm sitting there speaking to them as the professor. They didn't know that, hey, I've had this great postgraduate course from them. But moreover, the subcultural giants, the ones who understand how to cope, how to live. And until and unless you're ready to do that, can I give you one short little anecdote? In Malawi, in a place called Lilongwe, there's a fellow, his name is Tembo. And in Kiswahili, that means elephant. And I can assure you that Mr. Tembo has never forgotten anything I've ever taught him. He thinks of me as his professor, which is always something that causes my knees to knock, because when he says that, there's a problem that's larger than both of us. Oh, Professor, we have this thing that we would like to show you, and it's a ruptured uterus with twins floating free in the abdominal cavity. Well, that's your garden variety, the thing that happens to you every day, and I'm sure you'd be invited to have a go at that. The students will say to me, come quickly and take over because, well, no, let's go and help Mr. Timbo. Mr. Timbo is on the job trained by our successive missions. And Professor Lord, you know, I have never, you know, maybe I've never seen, no, just once I saw that. And you know, what I did then was, I turned to the student, did you hear what just happened? Mr. Timbo, who's never seen the inside of a classroom, has just taught a fellow with a dozen graduate degrees. Until and unless you are willing and humble enough to have that happen to you, that experience is going to be so much the less. So yes, at every point along the way, we have a lot of wonderful instructors. I'm just the usher that gets you exposed to them.
That's a great answer. I will give you a very pragmatic approach in terms of how we prepare people to go there. The first thing is, as was just mentioned, humility. You're not going there either as faculty or as a resident to teach everybody how you do things in the United States. That is really, really important. You're going there to learn, and if in any way to share your way of doing things, which very often is completely inappropriate in the local environment. So the humility is the first thing, but you also need, from a purely practical standpoint, you need to have a travel clinic. You need to make sure that all your immunizations are prepared. You need to have done some kind of reading on local diseases, on the tropical medicine aspects of that country, and you need to understand the language barriers if there are. In Malawi, most people that you're going to deal with in the hospitals, from a colleague standpoint, do speak English, but you will need to be able to understand some Chichewa or Swahili or whatever language is being spoken there. But again, you're not there. I tell all of our residents who may be a fourth-year resident and they're ready to go into practice and they think, I've got this, I'm going to go over there and train these people how to do some stuff. No, you're not. You're going to go there, and what you're going to learn is how to manage things in a completely austere environment. And that will teach you more than you probably learned in the last 4 years in the space of 3 weeks.
One quick comment I want to share with the transplanter of my one experience is that my anthropology degree is probably the single one that is better than the medical degree in how to get along with other environments. Every place I have ever been, and continuously, I am the minority outsider. And that takes a fair amount of humility and a whole lot of those wide open eyes and ears.
Okay, we have time for one more question.
We're always concerned about brain drain, sustainability, and teaching people in country. One of the issues that we face, and I'm sure you face it all over the world, is that the local people that you're training, if they work for the public health service, they don't usually make a living, they can't make a living with what they're paid. So they have to have their own private clinic and private paying patients. And then there's always this conflict between the two practices that they have. I don't actually have a good idea. I don't know how to solve that problem, but it is a problem that we've identified, and I'm sure you've encountered it. And I wondered if anybody had any thoughts about how to deal with that, because if we don't deal with that as surgeons and medical people and personnel going out, we're going to always face this brain drain problem.
Maybe I'll start and then pass it along. You know, I think you know, I am right here myself a result of brain drain. You know, I think there is really no absolute solutions to this problem. However, one thing I have at least learned in the Ethiopian physician community that lives here in the US, the majority of the physicians think, you know, or actually answer to our survey, that they left the country not because of war or safety issues, but more because lack of professional development. So I think as we develop these educational infrastructures, and as we develop this possible intellectually challenging and improving environments, I think that's one thing that might keep people around. The second piece is, I think these kind of solutions have to be local. There is really no way we can, provide that solution. And if you look at the College of Surgeons of East and Central Africa, they have a training program now, which is non-university based, but community hospital based. And what they have noticed in a very short period of time is that surgeons trained through those community programs have a 93% retention rate. And so they are hopeful. And this is really more preceptorship kind of trainings. And they think those individuals who really spend time and within the community and away from the cities and the universities tend to stay where they are trained and continue the community. Dr. Bass, Barbara Bass, she made a nice comment, which I really think is very reasonable. I really also think empowering women and getting women more into this field is going to be something of importance. They tend to be a lot more in tune at serving the communities more dedicated, and so there are a lot of those kind of strategies out there, but I think there is no one thing we can do, and unfortunately we face this.
To only give you one incidental comment that is just decrying the problem, Girma is well aware, and I am too. I live in a state called Maryland. You Texans, this is a big state, isn't it? It's like 1% of your volume in Texas. There are more Ethiopian physicians in Maryland than there are in Ethiopia. Do we want to encourage that in any way? Well, with a couple of exceptions, I would say. I'm not into indentured servitude. How is it possible to make that, giving the people the full capacity? Well, people go when they've got nothing to lose. Give them something to lose. Make sure that they have something there that they can't give up. PACS, you're going to hear about from Dr. Bruce McFadden, and I'll not say more since he will, but I've contributed a bit to that, which is raising up within Africa nationals trained in another nation in Africa. And now, through the help of a couple of important people, a wonderful woman that I will introduce you to by name, Dr. Arakana Chambahuri, who is the head of the African Union, all 52 nation states. The reason she and I got on so well is that she came to the US as a surgery resident in downstate in the Bronx. And that she is now a general practitioner, however, now is elevated to the head of the African Union. She has a mailing list, not a mailing list, but a phone directory as well as her emailing, of 452 of the diaspora of the African physicians. And she is making personal calls to say that the premier program for the African Union will be Mission to Heal, and they are invited to come to their native nation to see what they've left behind with modern facilities now brought back. And with that help, we not only cross borders freely, but we also bring some of those from the European and American diaspora and bringing them back. And two of them have said, I think this is the time. Because of the Millennium Goals and other things, it may be time to get on back. Being a much bigger fish in this brand new pond.
Your question is an excellent question, and I don't think that it's our problem to solve. It is a social issue in the majority of the countries, and this is not just in Africa. I've seen it all over South America. It's the same thing, where people who have given up so much to get their education, then feel that they need to provide the same for their children. And until you've walked a mile in those shoes, I mean, we've all been to countries where we've spoken to colleagues who tell us they earn $10 a day or some ridiculously low amount. And so the pressures on those people are very, very real. And yes, we've seen it. People will come in and they'll be the chair of the department or some lofty title, and you never see them. They're in their private practice and the services being run by untrained or poorly trained people. That's a social change, it's a long-term change, and it's going to take a culture change. What we're doing, if I would just focus on our local effort, is to establish an NGO with local Malawians, and then we provide full-time employment to everybody in those centers who, that's their only job. They don't have private practice. They're paid a fair wage, which is not a huge wage, but we recruit people who believe in that system. We hold them accountable to the same principles that we train and work under here. And I believe that as those young people advance in that culture, they will go out and spread it. And hopefully, if the country's small enough over a few generations, that will change. Hopefully the social systems and the economies of those countries will progress to the point that they'll accept that culture change. But we cannot fix that, and certainly not by talking.
Okay, I'd like to thank our speakers for their time.